Welcome everyone to the October 20th session of the WHO COVID-19 vaccine costing, financing, budgeting, and delivery webinar. Today's session is focused on operational microplanning for COVID-19 vaccination and experience with multiple products. Next slide, please. My name's Bruce Strumminger. I'm with Project ECHO, and it's our pleasure to be supporting this WHO learning series. And I have just a few housekeeping items to go over. First, we have interpretation today in French and Spanish. Please access that by clicking on the globe icon to the bottom right of the Zoom toolbar. When you click on that, you'll see English, French, and Spanish options. Click on the language you'd like to hear. If you'd like to only hear the interpretation and not hear the original language in the background, click Mute Original Audio. Next slide. We are really looking forward to your questions and comments today about today's topic. Please put those in the Q&A feature. That is also to the bottom right along the Zoom toolbar at the bottom of the screen. We'll be monitoring the Q&A and hope to get to as many of those questions as we can. If you have questions about IT issues or logistics or about the certificate of attendance, please put those in the chat and we'll try to help you out as best we can. Next slide. We are offering a live transcription, subtitles. They will be in English. So if you want to be able to read those, just click on the live transcript icon that's just to the left of the interpretation feature and to the right of the Q&A feature. Next slide. We are recording today's session, as all the sessions in this series have been recorded, and your attendance is consent to be recorded. Thank you for that. We'll be sharing the recordings of the English, French, and Spanish language versions afterwards, and we'll share a link in the chat to the websites where you can find the archive of all the recordings. We also will be offering a certificate of attendance through the University of New Mexico, where Project ECHO is based. And we'll put a link in the chat about 15 minutes before the end of the session. That leads to a brief survey. We really appreciate your feedback. It helps with quality improvement and to guide planning for future sessions. So please take time takes about 3 or 4 minutes to complete the survey, and then you'll get an instant certificate of attendance. Next slide. Just a note about data use. We take data stewardship very seriously and just want to ensure everyone that the data you share when you register, when you're putting comments in the Q&A, et cetera, that's all very carefully stewarded, and what data is shared is all de-identified. Next slide. With that, it's my pleasure to hand over the microphone to Santosh Gurung with WHO to formally welcome us today. Santosh.
Bruce, thank you very much. Thank you for the welcome, and also thank you for all updating us with the housekeeping rules. Greetings, everybody, and very warm welcome to today's session. So I am Santosh Gurung. I'm working with the EPI team in WHO headquarters, and I will be facilitating the sessions today, and also in terms of the discussions, I'll be moving and facilitating the discussions around the different topics. And just to give you an overview of today's agenda items, can we go to the next slide, please? Yeah, so this is more of a general announcement in terms of what are the recent resources that are available from on the vaccines aspect. And I think the first one is on the booster doses. I think WHO doesn't have a really formal or an official recommendation on boosters as of yet, but There is another SAGE meeting that's coming up around November, and hopefully there will be some concrete recommendations around the boosters. But as of now, there is an interim statement, and the link can be accessed in the PowerPoint in the slide. So in terms of the second update is the global strategy document around the COVID-19 vaccination. Its target to reach a 70%, a very ambitious target to reach about a 70% by mid next year in 2022, but also moving in a very direction, in a direction of about 10% by end of September. And then it's a 40% towards the end of the year, this year. And then it moves towards a 70%. So this is a very ambitious target, but yeah, I think we're moving in that direction as the countries are updating the NDVPs and more and more vaccines are made available. And the link can also be, the document can be reached in the link also in the slide. And just in terms of the COVAX facility, the briefing from the COVAX facility, we have a briefing session on the 21st of October. That's tomorrow, and there's going to be an update in terms of the supplies aspects of the COVID vaccines, but also more discussions around the updates around the new recommendations and any updates around the supply side of the vaccines. There's going to be a morning session and there's going to be an afternoon session. So this is mainly for the WHO and UNICEF country-facing staff, and the following week there is going to be a similar kind of discussions for the COVAX participants. To the next slide, please. Just to give you in terms of the series from the ECHO sessions that are coming up, is the one that we had today is on the operational microplanning, which we will go deep in a few minutes. But other than the next week, we have a session on the mini CPIs, and the following weeks, the topics are all addressed over there. Just to kind of give you an update in terms of the session on the 10th November, this was postponed last week, and the briefing has been scheduled for 10th November. Next one, please. So in terms of the session today, we're going to be talking about the operational microplanning for COVID-19 vaccination. We understand that the vaccine has already been introduced in almost all the countries. I think it's 3 countries that haven't introduced the COVID-19 vaccination, but the WHO headquarters and the regional teams have worked together with partners and developed an operational microplanning document. This is more a companion document to the National Development Vaccination Plan, which is more of a strategic plan, but this is more a document that provides a conceptual framework and a guidance around operation at the subnational level. So Usman would be presenting the outline of the document in the first segment of the session, followed by Ravi and Chris, who would be walking us through the digital microplanning and the GIS support of the COVID-19 vaccine. So I think the whole idea is on the programmatic side, we have the presentation, which is the first item, but I think also the innovation team is also going to be discussing about what the digital microplanning is actually kind of complementing to the work on the COVID-19 vaccination rollout. And there's going to be a regional perspective by Latif from the Afro team, who is going to give us a perspective around the multiple vaccines that have come into the region and countries, but also give us focus and some attention around some countries with how they have dealt with the multiple vaccines rollout in the Afro region. Next one, please. So in terms of the goal and the learning objective of today's session, if I may, it's basically to kind of put all this information around the operations and the microplanning that the various team and partners are working on, just to kind of collaborate all the information and inform and discuss on the various aspects of the microplanning of the COVID-19 vaccine implementation. Like I said before, the first objective, first agenda item will be more of sharing the conceptual framework or the guidance that would be released in a few days' time. I think it should be released by the first week of November. It's basically, and once the document is out, we will be sharing the link further for dissemination. And the second objective would be how countries can use the geospatial data and the GIS techniques to kind of improve microplanning and making sure there's an equitable distribution of health facilities and resources for the COVID-19 vaccine. So Ravi and Chris will walk us through those through the slides, and Latif would then give in from an Afro perspective around handling with the multiple COVID-19 vaccine products. Can we move to the next one, please? Yes, but before I hand before I give the floor to the first speaker, Usman, there is a few poll questions that we'd like to request all of the participants to kind of come in and give in an idea. So the first question is, have you been involved with the operational microplanning for COVID-19 vaccination? You choose your answer, whether yes or no. Have you used geospatial data or the GIS in your microplanning for the COVID vaccine 19 response? Is the second question. And the third one is, have you been involved with the planning of multiple COVID-19 vaccine products? So these are the three questions. If you could please take some time to respond to these questions, and then I can present you the response in a few seconds. Great, we have about 65 people who have already, 65% of the participants who have responded. Do we want to show the responses to the questions on the poll? Yes, thank you very much. So in terms of the first question, have you been involved with the operational microplanning? It seems quite a good percentage of the people that is in the session today have been involved, which is a 55% have been involved in microplanning, and the use of the geospatial data and the GIS in the microplanning for COVID-19 response. Majority of them have not been involved. It's a 91% that have not been involved, but a small percentage of 9% have been involved in the GIS microplanning of the COVID-19 vaccine response. And in terms of being involved with the planning of the multiple vaccine COVID-19 vaccine products, it seems that most of them, 59% of them, have not been involved in the planning of dealing with the multiple COVID-19 vaccine products, and 41% have been involved. So this is good to know. And with this, we are hoping that the sessions will be helpful in kind of getting you to understand all of these aspects, and maybe we can take a feedback poll towards the end of the session. So with this, I'd like to open the floor and welcome our first speaker, Usman, to talk about the guidance of the operational microplanning. Over to you, Usman. Thank you.
Thank you, Santosh. And good morning and good afternoon. Do you hear me?
Yeah, we can hear you.
Okay. My name is Usman Jia, and I'm a senior technical officer at GSI in Washington. With the ongoing pandemic, most countries have already developed their NDVPs, as you just said, based on guidance from WHO and UNICEF. Even some countries are in the process of updating their NDVPs using the second version of the guidance released in June. However, there is not yet a global microplanning guidance specific to COVID-19. Next slide, please. Today, we are going to introduce to you the microplanning guidance for COVID-19 vaccination. It is on request from WHO, and for a few months now that GSI has been working on the development of a global microplanning guidance, which will serve as, just Santos said, as a companion to the NDVP. We expect this microplanning guidance to support countries better plan and implement at the operational level. During this presentation, we will cover operational microplanning. Then we will spend some time to walk you through the guidance, its purpose, the various steps, and the conceptual framework. And we will, at the end, share some ideas on way forward for discussion. Next slide, please. This microplanning guidance was developed with contribution from partners listed at the bottom right of the slide. These are WHO, BMGF, UNICEF, MMGH, World Bank, IFC, and GSI. It is important to mention also that field staff from several countries have provided their feedback in initial drafts. This guidance builds on existing resources, including NDVP, regional guides, routine immunization documents such as RED strategy, and on recently developed tools by immunization partners. However, despite all these efforts, it is unfortunate to note that program managers in many countries are still facing challenges to implement COVID-19 vaccination, mostly at the operational level. This is why the primary target audience of this guidance is staff and health and stakeholders at district and sub-district level. Next, please. The objective of COVID-19 microplanning are to ensure that required resources for implementation at available timely, that equitable delivery and uptake are assured in the context of delivery of multiple vaccines with different specification. This is keeping in mind that all this should be done while assuring continuity and integration with essential health services, particularly with routine immunization program. And again, as for routine, the microplanning process for COVID should be led by district and local government authorities who understand the context and the challenges. And as a reminder, operational microplan is not just simple collections of spreadsheet and budgets. Next slide. As you can see in this slide, COVID-19 vaccines come with so many challenges, some of which are new even to the most experienced of us, and more challenges are to be expected. Some of the most common challenges are erratic and unpredictable supply, limited availability, even though there have been some progress in recent weeks, then shorter shelf life, complex vaccine handling and rigorous storage requirements, particularly for some of the vaccines with very specific handling requirements. Next, we have limited and rapidly evolving information, and finally, uncertainties about vaccine arrival. In addition to these challenges, there are others that are not listed in this slide, such as absence of VDM and the puzzle dynamic shelf life for some of the vaccines like Pfizer. Next slide. Other challenges we have identified are wide range target age outside of usual API, that is in many countries around 4%, to with COVID over 50%. Multiple vaccines with differing schedule, stretched health system in the context of limited human resources. We have also to deal with misinformation and rumors, and not to forget managing expectations and preferences. And finally, ensure communication about new vaccines. Next slide, please. Major considerations in COVID-19 microplanning are two: strategic and logistical. For strategic consideration, these are SAGE recommendations, alignment with NDVP, of course, and vaccine-specific recommendations that need to be factored and contextualized. Regarding consideration, logistical consideration, each of the 5 that you see below need to be looked at carefully, from first prioritization of high risk to second deciding delivery strategy, up to the last one, digital microplanning. In deciding delivery strategy, for example, there is a need for adaptation, as some of the proposed strategies, such as drive-through sites, are really new to health workers and are being tested for the first time in many developing countries. Next slide, please. The purpose of this guidance is, as I just said, to better support districts and health facilities in planning. It is a tool for this level, not for central level. It is developed to help facilitate stepwise, systematic bottom-up planning. This guidance provides also tools to assist during the process. It contains advice on engaging stakeholders and on leveraging resources at local level, which is important also. And more importantly, it guides to address rapidly changing situations that are the resultant of erratic vaccine supply, vaccine specifications, demand on uptake, financial and human resource availability. Next slide. The microplanning guidance is composed of 8 steps, and each step is divided into specific action-oriented activities. Planning formats are provided for specific activities with, again, stepwise detailed on use. The formats are adaptable based on context-specific requirements and can be used manually or digitized. Each step encompasses also planning for budget, advice on mapping wherever it is required, and finally, it provides links to additional resources on specific topics. Next slide, please. As you can see, here are the 8 steps, starting with determine the target, followed by estimate requirements and plan for storage, then determine human resources, plan service delivery, generate demand, and ensure communication. Throughout the implementation process, the plan should be monitored and reevaluated. It should be revised periodically based on newer guidance. It is important to note that any change, like, for example, introduction of another vaccine or lowering, for example, the age of beneficiaries from 18 years to 12 years, or even lower later, and this can happen in the next future, will imply revisiting the 8 steps. Next slide. This slide provides an overview of the conceptual framework. As you can see, it is very condensed with a lot of boxes, colored ones. However, I will try to walk you through with the few minutes I have. It shows the 8 steps, starting from, if you can look, the top left corner with step 1, determine target with its 3 related activities. Then step 2, estimate requirements. It is where we calculate the required doses of vaccines, but also ancillaries, and so on, up to the right corner with step 6, which is generate demand, that deals with community engagement and risk communication. Then at the bottom right corner is step 7, monitor implementation, which is followed by step 8, reevaluate the plan. So it's over the circle. This can happen anytime that reevaluation to meet the requirements of different vaccine in the pipeline, or assess feasibility of using new product, for example. A case I had to deal just last week with a country I will not name is that health facility, for example, have been vaccinated with AstraZeneca up to now. And the country is facing shortage of AstraZeneca, while many people are waiting for their second dose. And a substantial quantity of other vaccines, Moderna and Pfizer, has just arrived in the country. And the question is, should the country decide to use the received vaccines as second dose on top of AstraZeneca? Big question. Whichever will be the decision will imply revisiting the microplans that district has already developed. This small example shows us that microplans should be live documents involving reevaluation and revision based on context. Please note that the colors used in steps match the colors in the sections of the guideline, of the guidance, to facilitate the navigation into the document. You can see also that under each step, we have not only related activities, but also the budget in orange color and the mapping exercise in green. For each of these steps, the details are well developed in specific sections of the guidance. Next slide, please. In this slide, we have the layout of steps and activities as just described in previous slide. Here, for example, in step is the step 1 that I showed earlier, which is determine the target with its 3 activities: prioritize high-risk group and vulnerable individuals, estimate population of each of the target groups, compile target population of different groups, and for each step guidance, advice, and tips on budgeting and on mapping are also provided. For most of the activities, formats are available in the annexes of the guidance. Here, for example, in this slide, both activities 1 and 2 have formats. On the right side of the slide, we have format 2 as an example, with underneath explanations on how to complete it step by step, and is the same for all the formats that are provided in annexes. Next slide. Similar process applies for step 2, as you can see, in step 3, and for each of the following steps up to step 8. Next slide. The guidance includes 16 formats. These formats are similar to the ones used for planning in routine immunization and vaccination campaigns with standard terminology. Therefore, health workers will not be too disturbed with these formats. The proposed formats can be adapted and modified according to requirements, and they can be easily converted to computer-based tools. Overall, all provided tools in this guidance can be and should be adapted based on context-specific requirements and should be used in harmony with plans and guidance already in place. Countries are encouraged to adapt the information in this operational guide based on their current COVID-19 vaccination situation. Next slide. In this last slide, we are going to share a few ideas on way forward. In short term, the guidance should be disseminated to the districts and sub-district level and initiate use. In midterm, organize orientation of planners and program managers at district and health facility level using standard package. The guidance will be field tested and improved before another version of the guidance is released. Sometimes maybe if we agree with WHO during first half of next year. In a longer term, we are thinking of the development of a user-friendly digital tool based on this guidance to facilitate planning by automating planning to avoid duplication and manual errors, using cloud-based technology, linking facility plans with districts and national plans, and finally by integrating GIS, digital mapping applications, which is one of the next topics on the agenda. Thank you for your attention and happy to respond to your questions.
Usman, thank you very much for sticking to time first and also giving us an overview, but also kind of walking us through some of the sections to kind of give an idea of how this is going to be functional at the sub-district level. And as you said, this is going to be a living piece. And once we have it published around the first week of November, we definitely want to think about it in terms of the midterm and the long term of how to make it more, see how the countries kind of receive this document, but also then work on an update that is more based on the request that's kind of coming out of the field test and the country's feedback on all of the guidance. So thank you very much for this presentation. And we open the floor, but for questions and answers. I think if there is any specific question and answers to the guidance document and the overview that Usman presented, feel free to put them in the Q&As. Let me just very quickly look at the Q&As. We have none so far, which means that the presentation was either too complex or it's just or maybe it's very clear. So we let's see. There's some questions and. Usman, if you would also like to take some time and look into the questions, and if you feel you want to type them or you want to answer them live, feel free to do so.
Okay. So I see one question. The first one expected to use the steps, and one question, very interesting presentation. Are you going to share copies of the microplanning guidance? I think you have already on your introduction talked about this will be released as early as beginning next month, in few days. So it will be available. I think Santosh has already said that. Very good day. Thanks for the presentation. Is someone who is using the guidance document expected to use the steps in that order, or can one step override another? Yes, I think we have the 8 steps. And while you are going through the steps, you can, some of the details are not changing, so you keep it as it is. It's based on the context in country. So you are not obliged to Next, there is no other one.
Yeah, thanks, Usman, for taking on the response to that question. Yeah, I think if the questions keep coming, feel free to put them on chat and in the Q&A section, and then Usman or I would respond to the questions. So with this, we move to the second agenda item, and over to you, Ravi and Chris, to make the presentation on digital microplanning.
Thank you, Santosh. Yeah, that was a good presentation from Usman. There's a lot of things for us to learn from that as well. Can we move to the next slide? Yeah, my name is Ravi Shankar. I work at the headquarters here in Geneva in the Department of Data and Analyticals. We support the WHO GIS Center for Health. It's a center which supports various programs related to the use of GIS technology, including satellite imagery, field data collection, and digital aspects related to geospatial technology. Along with me is my colleague Chris Jung. Can we move to the next slide? I'll briefly mention about the session overview. So what Usman laid out is a perfect foundation for a complete microplan. One slide nicely showed various boxes where there was one small item there called mapping. So that is what we are going to deal about, that particular question about the mapping. The question in front of us, which was put like a year ago, is like, is there an equitable distribution of vaccines to all the population? Of course, we know that there's not an equitable distribution between countries, but the question, what we are trying to address here is, within a country, is there an equitable distribution? Does everybody get the vaccine as it is needed? So to do that, on the digital microplan side, we put some questions in front of us to ask these simple questions. Where are the current health facilities? Do we know the locations of these health facilities which manage the COVID-19 vaccinations? Of course, if you ask anybody in the country, you know, oh yes, there is a center there. Do we have a comprehensive map of all these facilities within the country? That's the first question. The second one is, where are the priority population that need access to the health facilities? This looks like a simple thing, but it is sort of a complex when you add the spatial dimension to it. The priority population in terms of age group, in terms of health factors, we know that these groups exist, but they're all intertwined within the fabric of the entire population. So how do you know where you have your priority population which you need to focus spatially? Because that is in close relation to reaching to the health facility, right? These people have to go to the health facility to get vaccinated. And the third question is percentage of people that can reach to the health facility. That is, we call it as a catchment area, or the area which covers a certain population. Why is this important? Because this is not like a normal primary healthcare center, right? This needs little more to actually do an administer an COVID vaccine, because it needs cold storage and other things. So it means you don't vaccinate in all the places. Even in places where we live, there are so many hospitals, but only few hospitals offer this. So that information is very important. The fourth one is on the travel time. What is the travel time it takes for the people to reach to the health facility? And the last question is, does this health facility need additional support? After the evaluation, what Usman was talking about, might be this health facility cannot cover all the population. Only during analysis, you'll know that. Then can we offer more, a mobile or a temporary facility to serve the population? If so, where are these locations where you want to put these temporary facilities? That is what GIS can answer that. And the GIS Center, we try to help them, the countries, with our partner UNICEF and WHO were co-partners in this. With other donor partners, we actually try to help the countries on answering these questions. I'll let my colleague Chris to drive the next slide. Next slide, please. Over to you, Chris.
Thank you, Ravi. My name is Chris Jung. I'm a consultant on Ravi's team at the WHO GIS Center for Health, and I'm based in Rwanda. So the question that we're here to answer today is, what is digital and GIS microplanning, and how can it help improve the programs for COVAX, for COVID-19 vaccines, and beyond? Next slide, please. So Usman gave a great presentation summarizing the background and traditional based microplanning just before this. So I'll take a step back and summarize that and focus on a few things that are relevant to this session here. Microplanning is a decision-making process. And it allows us not only to find the people that need to be vaccinated, but to develop the plan and the workforce management to reach those people. It's used to identify priority communities and vulnerable communities. It addresses the barriers to access and finding people that aren't normally within the health system. And it develops these work plans as solution-oriented problem-solving steps. And microplans are local. They are at the lowest level. It's usually a national or district initiative to engage in the microplanning, but the actual plans are very detailed and down to the lowest level. Next slide, please. There's a long history and a lot of excellent use cases and experience to draw from traditional paper-based microplanning. There are some challenges with it, though. The transparency, in the sense that it's difficult to share widely these microplans and get good visibility into what the planning is involved. The accountability, in that it's difficult to identify populations that may have been missed or gaps based on these traditional plans. The technology is somewhat limited with traditional spreadsheets, and not all of us are great hand-drawn cartographers and can benefit from some tools that help improve those hand-drawn maps. Next slide, please. So GIS microplanning is not something totally different. The purpose is to improve traditional microplanning and paper microplanning through geospatial data and GIS systems and tools and techniques that have been developed to bring these into sort of a modern electronic systems. The same process takes place with mapping local areas, done using satellite imagery, using detailed footprint data on where the buildings are, and it's data-driven. And using whatever geospatial data is available in the countries, and if necessary, and quite often, part of the process is to improve that baseline geodata and improve the data that's available for the mapping process. Next slide, please. So we can look at some of those inputs that go into the system. The most foundational is probably the satellite imagery. It's used to generate these detailed maps where you can see the layout, the terrain, buildings. It needs to be current and recent, and it needs to be at a high resolution so that you can identify individual attributes and components on the ground. The next is a layer on travel time, and that incorporates, previous slide, please, incorporates the roads network, or in certain cases, much more detail down to the level of vegetation that's present, the rivers that might be there. Quite often population would be walking instead of driving to reach the health facilities, or in the reverse, if you're doing a door-to-door campaign, you'd have to know how to reach these individual households, and that travel time is computed based on these layers. The spatial population is foundational and key. This is what Ravi was talking about in identifying exactly where the population lives. And to do this right, it needs to be disaggregated as well in terms of by age. COVID, we're targeting the more elderly populations. With a lot of traditional vaccines, we're targeting the under 5 demographic. Also should be divided by gender. The disaggregated is more helpful for the spatial population data. We need to know where the health facilities are. Usually we have most of that information, but we want a complete set of health facilities, all geotagged with the coordinates. And then the final layer is the catchment areas. Which people are assigned or likely to interact with which health facilities. And that will not only let us know who's coming to each facility, but where those gaps are and who's not connected to a health facility. Next slide, please. So there's 3 questions that we want to answer with digital microplanning. Where is this population? And that is based on the layers that we talked about before, the spatial imagery and bounding box. In particular, we look at household level footprints. Where are the health facilities? And not just where, but what's involved with them, what type of facility and its capacity, how many people can that facility interact with? And then finally, how do we connect the two? That's looked at as travel time, either driving time or walk time, and also looking at a spatial view, a map view of where these people are and where the catchments are and where the catchments may overlap or have gaps. Next slide. So advantages of digital microplanning over paper-based microplanning is that it helps us ensure that equitable coverage is reached. We want to look for overserved areas. Often in an urban environment, you might get populations that are within walking distance of several facilities. In a rural area, you might get 4 or 5 hours transit time to get to the nearest health facility. We want to plan and redistribute our facilities and our resources to the most efficient and optimal use. We want to improve the level of detail that we're able to reach, so that these microplans are fully complete and down to the last household, and also enables us to track workforce management and assign the right number of people to the right area based on the amount of demand that's going to be in that area, and then also follow up with them as we go. We want to improve accountability and transparency, and then it helps us identify problematic areas, more challenging areas, either refusal populations, special needs populations, physical areas that are inaccessible. For instance, perhaps it's a flood season. Vulnerable populations, whether they be migrants or IDPs or people affected from disasters and such. Next slide. This is just a quick image of what an application might look like, where we've color-coded the amount of time it takes to reach to the health facility, and you can see that people living in a particular area have an estimate of how long it would take them to reach, and you can target areas that have a certain gap to either move health facilities into those areas or help outreach teams to reach those people. From the next slide, Ravi will talk about an example in Somalia that we've used this before and give some field experience.
Thanks, Chris. Quickly, I'll not take much time. So in Somalia, Mogadishu, we had an opportunity to support polio program to do a digital microplan. Very simple. Digital microplan also involves a lot of community consultation and community participation. So we had taken a big district and then we have taken a big area to cover, where there are almost like 1,900 vaccinators who are going to the field to vaccinate every child. Because this is a polio example, they go to their DFAs, the district field assistants, and can we go to the next slide? So what actually we did is, we took the whole area and every supervisor had like 5 teams under him. We asked them to, can you map your 5 teams extent? So each person said that my team goes from here to here. So all the 5 teams put together became as DFA area. We mapped them in a digital format. Very simple exercise. Think about this doing in a Google Maps. You can go and draw in a Google Maps like that. We draw their bounding areas. Then what we need is next point. Next slide, please. We put the population over it. That's what the spatial population. We just overlaid the spatial population on top of it. And we found out how many people are actually living in that population. We came to and surprised that there are some supervisors who are managing 5 teams, which cover like 1,500 people, whereas some areas, you have population which is up to 31,000 are covered by them. It came to a big surprise to us and things, even though the quality of the campaign was looking very high, still the virus was circulating. So there was a mixed challenge and things. The country team was doing a fantastic job on getting this. But then, can we go to the next slide? What we actually realized is there's a lot of IDP camps which started coming into the play here. So it means slowly there are people coming and settling there. Small. It's not an organized IDP camps, most of them. They're just open spaces and they're settling there. But these are also people who have children, and those children also have to be vaccinated. So this made to rechange the whole microplanning strategy to a great extent, so that it exactly knew where people are living, and also to distribute the workload for every vaccinator or for the vaccinators, supervisors, team areas. And then it started yielding better results. And the next slide, please. Conversely, the other example we can do with this is, instead of people going to vaccinate the children in the house, what in case if they come to the health facilities? So this is what Chris was trying to tell about drive time analysis. We did a drive time analysis to support the IPV vaccination for polio. It's an IPV short vaccination for the children. Then we found that this is what a mother could take and walk or go to the nearest health facility through and walk. So we found that the current health facilities cannot cater this. So then it gave options to put new health facilities or outposts or mobiles or temporary posts. And then we also exactly know where to put them. So it becomes that these locations are not by chance, these locations are by choice. Thank you. I stop here. Over to you, Chris.
Thank you, Ravi. Next slide, please. We have limited time and we've almost reached the end of it. So I will move through very quickly, but please be assured we will share the presentation with everyone. And then we have a website with all of the links to the following information that I'll share with you and will be available for more questions too. So we are part of the GIS working group. It's co-led by UNICEF and ourselves. And we have many other partners that we'll show later. We are helping countries to pursue digital microplanning and to improve their existing systems. Some countries are starting from very low level. Some countries have a lot of experience with this in the past and just want to take the next step and improve. So we're trying to facilitate moving forward. One of the things that we're doing is needs assessment so that we can find out where countries start. Next slide, please. We have a pretty simple multiple choice mostly survey that's available that countries can fill out. It's targeted, for instance, for either the Ministry of Health or UNICEF or WHO country office to complete. And it lets us know what the baseline is and what we need to work on. Next slide. We use that information to divide countries into 3 tiers, whether they are tier 1 and mostly ready to begin right away with their GIS microplanning, down to tier 3, which they're starting from the beginning. And we use that to tailor the assistance that we can provide to countries and the recommendations that we have. Next slide. So there are many people working on these problems, and they have been for many years. For instance, Ravi mentioned polio has been working on digital microplanning for a decade or longer. Next slide. As part of our working group, we've engaged many technical partners. There's some logos there that you can look through. It's well over 40 partners at this point. We're meeting with them on a bi-weekly basis. And beyond them, we're also engaging with the global donor and coordination partners. As part of the core team, we have the World Bank, Gavi, Global Fund, CDC, Bill and Melinda Gates Foundation, and sometimes some others. And so we are coordinating our efforts and also trying to connect countries to the right resources that have the skills and experience and data that they need to move forward. Next slide, please. Each of these technical partners, we have an offering deck, and you can find that on our website. It just gives a summary. It's self-reported, and it's what they work on, what their experiences are. And if you are looking for a partner that meets their experiences, you can reach out to them, or you can ask them to complete your RFPs. Next slide, please. We're always asked, how much is this going to cost? And especially when countries get around to applying for funding, either through the Global Fund C19RM, which is mostly completed, or through Gavi's CDS, which is coming, the full application round has just begun. We need to know how much to ask for and how much this is likely to cost. Next slide. We have an Excel-based budgeting tool that we've created that we can work with you to make some of these estimates. And it looks at three main criterias. First, obviously, is what do you want to accomplish? At what stage are you at right now? And what are your goals and the activities that you'd want to pursue? The next is that tier of, based on the assessment of where are you starting from, whether we need to make it this a 2-year-long program that creates the very basic foundational layers, and we start from there, or whether most of these layers already exist, and then we can move on to using the tools, which can be much quicker. And then, of course, the size of the country. The cost of a program in Nigeria would be much greater than the cost of a program in Rwanda, say, just sheer number of people and the amount of geography covered. Next slide, please. So currently we're working on a handbook for digital microplanning. This will be a complement and an extension of the document that Usman was talking about earlier. And it's a practical field guide on how to do digital microplanning. Next slide, please. We are engaged with many partners on this, and the goal is to create what we're calling a cookbook, a step-by-step guide, and it looks at the planning, budgeting, implementation, monitoring, and evaluation of the whole digital GIS microplanning process. As I said, it builds on the document that's soon to be released from Santosh's team. And we are drawing from experience from a large group, a task team that already has well over 80 people from many organizations that are participating in creating this document. It will be hopefully completed by the end of the year, but December is our target. But it will not be one and done. We hope to, we will roll it out in several countries as a pilot early next year. We'll continue to follow it and get feedback, and it will be an iterative process where we will update the document based on country experiences and what we've learned. It will also be adapted to an online e-learning course that some people will find more value in using a learning module as opposed to reading a static document. So if you have experience in this domain, if you have worked on GIS microplanning, and if this is something that you are passionate and interested in joining, please send me an email. The task team has begun, but we have much work left to do, and we'd love input from a wide range of experts into this document. Next slide, please. Just to mention that vaccines are not the only use for digital microplanning, and in particular, COVID-19 vaccines are not the only use. It can be used, for instance, to reach zero-dose children, for makeup campaigns for routine immunizations that may have been disrupted by the last year. It can be used for supplemental immunization activities for polio or measles. Malaria use cases are very common for distribution for insecticide nets, and we all hope that the malaria vaccine will be rolled out widely soon, which will be able to leverage these types of tools. And then some of the things we're looking at and are being experimented with right now is, for instance, using these tools to micro-target communications to fight vaccine hesitancy, misinformation, that sort of thing. Next slide. So thank you for listening. There's a link here for our working group's website where all of this information is contained. I will share that in the chat as well. The email for our team is gisupport@who.int, and we're available to share whatever information, questions you have to ask for us. So thank you very much.
Thank you so much, Chris and Ravi, for this really good presentation and really the collaborative work with the team. And as Chris and Ravi mentioned, that really, I think there is aspects of microplanning and just in terms of the steps and how to from the programmatic side, I think it's what Usman presented, but also this is the document, the guidance on microplanning is definitely going to be feeding into the handbook that Chris has mentioned. And I think this has really been collaborative and in terms of how one is going to complement the other. So with this, I am going to open the floor for questions, and I can see Ravi is taking quite a few of the responses in terms of responding to the questions, but I can see a few questions that's unanswered. Maybe Chris or Ravi, would you want to take that live, or do you want to type an answer? There is a question that states about, do you have examples of where GIS mapping has been used to help identify high-risk populations like elderly for the COVID-19? That's one pending question for you. Maybe if you want to take this up.
Yeah, maybe I can take that, Santosh. So we actually did not directly implement it, but we know that in the US, they actually use the GIS technology to identify the high-risk population. So in some of the states, including California, I know that because we know one of our technical partner had been engaged in a project there. So they had been heavily engaged in identifying high-risk population at the neighborhood level. So for every neighborhood, they identified that and they did a spatial mapping of that. And they really found that the places where you had the elderly community or care center for them, around that you had a lot of population there. So that needed a slightly different approach for the vaccination.
Thank you, Ravi, for the response. And I can see there is no further questions that's unanswered. So thank you once again, Chris and Ravi, for your session. And I think we're just okay on time. And now just to build up in terms of, you have the guidance from the operation guidance and microplanning that Usman presented, and then we took it over to the digital microplanning team, who is also working on the handbook. So, and just to give in a more country perspective or a regional perspective of some of the aspects with the operational microplanning, is this multiple products with the COVID-19 vaccine. This has come across as a big challenge in terms of the operations around the vaccination for COVID-19. So with that, we have I'd like to invite my colleague Latif from AFRO to present on how the region is kind of dealt with this operations around multiple products for the COVID-19 vaccination, both from a regional perspective, but also they maybe dive a bit into some of the country's aspects. So over to you, Latif.
Thank you. Let me know when you've put up the slides. So my name is Latif Negeta. I work with WHO Afro as a consultant, as an immunization integration officer. So I'm going to talk about the regional experience with multiple vaccines. Then I'll give 2 examples, an Anglophone country and a Francophone country, and how they are dealing with multiple vaccines. Next slide, please. Thank you. So vaccine supply in Africa has substantially increased in recent months. There was a steady increase in vaccine supply. From March 2021, we had received about 27 million doses, and that steadily increased to 83 million doses at the start of August. But then from August to now, October, the number has increased dramatically, which is very good. Now we have 248 million doses as of today. And you should see the rate of change that when I sent these slides on Thursday last week, we had received 236 million doses. And today we have 248 million doses. So as you can see, the vaccines are coming from different sources, from COVAX, from AVAT, and from bilateral partners. And as you can see that bilateral partners constitute to a large proportion of the vaccines that have been deployed in Africa. And then COVAX doses are second with about 100 million doses, and then some from AVAT. Next slide, please. So this slide just shows us how many, which vaccines we're using in Africa. And as you all know that AstraZeneca was the first vaccine to be shipped to Africa. So this is the large proportion of about 31%, which is followed by the Chinese vaccines, Sinopharm and Sinovac with 20 and 18%. We also have few countries with J&J and Pfizer, and the least used vaccine is the Covaxin vaccine developed in India. So in the next slide, I'll show you the complexities of having multiple vaccines. So next slide, please. So on this slide, you can see that we have 9 vaccine types in Africa with a range of 1 to 6 vaccines per country. So there are some countries which have 1 vaccine, and there are some countries, let's say like South Africa, with 4 vaccines. And the countries that are in white, Eritrea and Burundi, and these countries are not vaccinating yet. They have not joined the COVAX. So having multiple vaccines necessitates a lot of planning for the countries to prevent expiry, and also to scale up the utilization of these vaccines. Next slide, please. So at a regional level, I would just like to share with you some of the strategies that we have used to managing these multiple vaccines. So the emphasis has been much on effectiveness of the vaccines rather than the vaccine type itself, because we know countries have a preference of which vaccines they want to use, usually based on where it's coming from. And also we've advised countries through interaction reviews that we've conducted that it's best to deploy one type of vaccine at a time nationally, if it is possible, starting with those that have the nearest expiry date. And then also at a subnational level, you would want one type of vaccine in a particular province or a particular district. And then at a health facility level, in order not to confuse the healthcare workers and to avoid mistakes happening, it's best to have one vaccine type at a health facility level. And then also deployment of vaccines with ultra-cold chain requirements near the central store, so that you have, because we know that it's rare for rural areas to have the ultra cold chain requirements that are having in central positions in countries. So it's best to have those deployed close to the CBDs, and then the rural areas will have the ones that are easier to store, the ones that are 2 to 8 degrees Celsius. Next slide, please. So on this slide, we also continue the strategies that we're managing at Afro level. So timely notification of vaccine arrivals. It is very important that countries know exactly when the vaccine is arriving and they know beforehand. So it helps them plan or update their national vaccine and deployment plans. And that leads to better sufficient cold chain capacity at national and subnational level. We need to have clear guidelines at national level and also at regional level for handling these vaccines. Supervision is very key to handling these vaccines because all these vaccinators need very good training and also frequent reminders, especially with multiple vaccines having different requirements. That means that you cannot just have one training of AstraZeneca vaccine and then you start deployment, and then 2 months later you get a J&J vaccine, and you need to have a refresher training for that particular vaccine. So that supervision is very, very important. Now, adherence to the first expiry first out, or some call it early expiry first out. That means when you have multiple vaccines in a country, you see which has the shortest shelf life based on the date at which it was shipped. Because as I said, you see some of the bilateral partners or vaccines that are donated bilaterally, some of them do have a shorter expiry timeline than others. So you want those ones administered first, and then the ones with the later timeline administered later. Next slide, please. So some of the challenges we faced is that countries were then using heterologous mixing, which is the mixing and matching of vaccines, such as when you combine a viral vector vaccine with a messenger RNA vaccine. And this happened because in some instances, there was a delay in the arrival of the second dose of the vaccine, such as the AstraZeneca vaccine. I can give you a close example of Malawi, which received the AstraZeneca vaccine, and then it took time to get the second dose. And between that, the country had already received the Johnson vaccines, and people do not understand that you can't get the first jab as AstraZeneca and then get a second jab of the J&J vaccine. So some vaccines arrived, and then the hesitancy now in the countries has also led to what I would call vaccine shopping, where people are actually choosing, no, I don't want this vaccine, or someone told me this is better because of ABCD. That's why I said the message has to be on effectiveness. Yeah, so having multiple vaccines in countries gives people options. So that's also a challenge because they might not want to get a certain vaccine. So then I will now give an example of what happened in Zimbabwe. And after that, we'll have an example of what happened in Cameroon, just so that you get a closer look. Next slide, please. Next slide, please. Thank you. So in Zimbabwe, they had the Sputnik V vaccine distributed in the city center, which is in Harare, for convenience purposes of vaccine storage, because as you know, the Sputnik V can be stored as a ready-to-use solution in water that is frozen at the common home freezer storage temperature of -18 degrees. Then they also had Covaxin. So because Covaxin can be stored at 2 to 8 degrees Celsius, they opted to have the Covaxin distributed in the rural areas and then have the Sputnik V in Harare in the city. And that's how they managed the two vaccines that they had to use at the same time. But then it ended up that by getting the second dose of these vaccines, they ended up having the second doses at the same facility. So that created a problem where you'd have a health facility with both Covaxin and then the Sputnik V. Next slide, please. So some of their best practices in Zimbabwe included development of the National Vaccine Deployment and Implementation Plan, the NTVP, and then they established a national COVID vaccine pillar response team at national level, which was very good. And then they have a robust routine immunization program with very high coverage rates routinely. And then the distribution of the vaccines was based on the target groups, but then by each province. Next slide. So some of the challenges that they faced was that they had inadequate capacity for the -20 freezers subnationally. Like I already said, the pre-notification of vaccines arrival by manufacturers was slightly delayed. And then they also had remote logistical support in view of COVID-19 lockdowns. So with lockdowns, it made things more difficult to move around, and that applied to all countries. So they had to get waivers to move around, and then sometimes those waivers took time to process. And then obviously the global vaccine shortage, which caused a delay in vaccine supply, but the delay was more impactful when they had already given one dose of a particular vaccine, and then they had to wait for the second dose. And then people were worried about missing the vaccination window for the second dose. Next slide, please. Then we will discuss the experiences in Cameroon. So Cameroon had Sinopharm from May 2021, and then they received AstraZeneca vaccines in May. So they prioritized the AstraZeneca vaccines because they had a shorter shelf life of expiry in July. So they sent the doses in the northern area of the countries, especially in areas where they knew that the vaccine would be consumed faster, like in army barracks, in military camps. And then after it was consumed, then they received the Johnson & Johnson vaccine in July 2021, after they had consumed all the AstraZeneca vaccine. So that was a good example of how they managed 3 vaccines in the country based on when they were arriving and also their expiry days. Next slide, please. So some of the best practices they had were similar to the ones in Zimbabwe, having a good NTVP plan. They had a daily monitoring of stocks at regional level, the timely delivery of vaccines and consumables at vaccination centers, and then they intensified campaigns to drive vaccination and increase uptake of vaccines. And also, they also redeployed the AstraZeneca vaccines between regions and districts to avoid wastage when the expiry date was nearing, when it was nearing the expiry date. So the next slide, which is also the last slide, please. I will discuss some of the challenges that they faced. So managing several vaccines at each vaccination site was a challenge on their end. Having high or inappropriate wastage due to knowledge and skill gaps of vaccines. So as the picture you can see, those are vaccines that have been packed to be destroyed or incinerated, and that's a large volume. So low reporting of vaccine usage at district level is a common challenge. And this is not just at a district level. At Afro, we've seen that at a national level, and not just in Cameroon, but generally in most countries, the reporting has been lacking. So we need the reporting to know the vaccine consumption rate in a country, which also informs how many vaccines will be deployed in the next consignment to a particular country. So sometimes a country might be performing well, but they're not reporting it in the dashboard. On our end, you see it as a country is not performing well or has too many vaccines they're not consuming. So we always need to get in touch with the countries and pick up the phone and ask them how many vaccines have you used, how many are nearing expiry, so that it determines the next consignment or the next shipment to a country. Also, they had stock out of some consumables, which is also common in all countries. And then that was my last slide. Thank you very much for your attention. That is all.
Latif, thank you very much for sticking to time and also giving us a very informative presentation. And like what I mentioned, I think we wanted to give a feel in terms of one of the challenges with the microplanning and the operations around the vaccine implementation is the multiple vaccines, and Usman talked about the 8-step process. So this is definitely a section which is incorporated in the guidance document about how do you handle with the multiple products? How do you need to reevaluate your plans in the country? So this is more of a hands-on example to the guidance document and how the Afro region and some of the countries, so very good examples from the countries also. So really thank you to the Afro team and Latif for making the presentation. So if we have any questions for Latif, please feel free to put them in the Q&A sections. I see none so far for Latif for the multiple vaccines rollout. But yeah, I think as if any questions, please put them in the Q&A section, and we will try and address them now over the chat. So with this, I'd like to really thank all the speakers. We're right on time. We're good on time. So I'd like to really thank all speakers for some very informative presentation and also giving us very useful resources to kind of share with the participants. With this, before we get on to the closing section of today's session, I'd like to kind of just take a feedback poll and just get a pulse in terms of the questions that I'd asked in the introduction to kind of get an idea of what is the understanding around the guidance document, what is the understanding around the geospatial use of digital microplanning. So if you could please put the questions for the participants to kind of respond, I'd appreciate that. So there are two questions for as a feedback poll. The first one is, after this session, I do have, and I'm aware of the conceptual framework and the 8-step process of the operational microplanning for the COVID-19 vaccination. So your responses to that would be appreciated. Yes, we have a good understanding, somewhat of an understanding, or no understanding. And in terms of the second one, after this session, I understand how countries can use the geospatial data and the GIS techniques to improve microplanning for the equitable distribution of health facility and resources for the COVID-19 vaccines. So all of the information that Ravi and Krish shared, if you thought that was helpful, please respond yes. If you feel that that was not somewhat helpful, then or it was not helpful. So just a few seconds to respond for the participants, and then we close the poll. So we see a good 45% have put in the responses. With a few more seconds, I think we have 53% of the participants who responded. Yes, please. Can we have the results to the poll, to the feedback poll? Yes, thank you very much. And I think to the first question in terms of the presentation around the guidance document, the conceptual framework, I think 87% of had a good understanding of the guidance documents that's going to be published very soon. And in terms of the second session around the geospatial use of data, 63% is responded as to they have a good understanding around the digital microplanning for the equitable distribution of the health facilities and resources for the COVID-19 vaccines. 33% said somewhat aware of, had an understanding, and 4% had no understanding in terms of not able to understand the session completely. So thank you very much for your responses to the feedback poll. And yeah, I think we can stop sharing the poll. Can we move to the next slide, please? Yeah, I think before that, I just also wanted to kind of highlight to the participants that there was a survey that was put out in the chat, and we appreciate your kind of feedback on the survey. It's just a 5-minute survey. And by the end of the survey, you would be able to print a certificate of attendance, and that would, or you could submit your feedback on the survey. So we'd appreciate your responses on the survey. And all of the information on the webinar materials and really evolving piece of information on all of this would be very much available in our TechNet resources, and you can find all the links over here. So this the guidance document on the Operation Microplanning would be released around the first week of November. You can find it here, but we'll also share the link. The handbook would be ready by the end of this year. So on digital microplanning. So all of the resources is something that would be put it in the TechNet link. Next one, please. Yeah, just before we close the session, we wanted to kind of inform to register for the next week's session on the municipalities and the lessons learned around and highlights sort of from the regional perspective. So the session is on 27th October, next Wednesday. So, and the registration link is available here. Next, please. So yes, thank you very much all the participants for your participation, and also for your Q&As in making this discussion also very productive. And I would also, before closing the session, I would like to thank our translators, both the French and the Spanish translators, for delivering the session in Spanish and French. So I'd like to thank that. And with this, thank you everybody for all the speakers, all the participants, all the team for making this a successful session, and see you next week. Thank you.